The goal of that talk is to go over what skill set and how do you modify your original standard of care surgery for patients with intraocular inflammation, uveitis, that get glaucoma, to get the best possible outcomes. The challenge in those patients is the eyes are inflamed, so you're starting with eyes that are already inflamed. The tissues are more fragile because of the chronic inflammation. If you just do your surgery the way you would do it in eyes that are not inflamed, you're likely to run into trouble with the intraocular pressure, because the pressure can be very labile after the surgery. It can be too low or too high, so you have to make sure you avoid low pressure by tying the tubes, stenting them. You have to make sure that your incisions, the wound is closed with not under tension. You have to make sure that the scleral tunnels that you create for those tubes are longer, because the tubes are more likely to get exposed over time because the tissues are so fragile on the ocular surface. It's not infrequent that patients with uveitis will get glaucoma, and their glaucoma is, for the most part, can be kept under control by keeping the inflammation under control. So you have to work in conjunction with a uveitis specialist. And the majority of patients you can get under control with medical treatment. I would say maybe 10 to 20% of patients will not be well controlled even with medications, and those are the ones that fall into the surgical category where you have to do surgery for them. For that subset of patients where the pressure is uncontrolled but can be brought under control with medical treatment, I think uveitis specialists do a superb job with that, because they treat both the intraocular inflammation, which is essential in controlling the glaucoma, and they can treat the glaucoma medically. But I think it's teamwork, and when the intraocular pressure is not adequately controlled with medications, that's where a glaucoma specialist has to be involved in the surgical care of those patients. I think it's just a difficult disease. It's a challenging disease to treat. It's chronic in a lot of patients. The course can be very unpredictable, and it will slowly take away vision if not treated properly. I think it's one of those areas in ophthalmology where it's a team approach. So often, you would have the uveitis specialist, the glaucoma specialist, and often an immunologist or a rheumatologist that would be also involved, depending on the etiology of the uveitis, to try and control the disease using steroid-sparing agents, because the steroids will make the glaucoma worse. So it's often 3 doctors that can be involved more or less in the care, on and off to different degrees, depending on the stage of the disease and how it's behaving. I think treating intraocular inflammation has evolved so much over the past decade or so. We have a lot of new medications, immune modulators, biologics that we use. I don't use them as a glaucoma doctor, but my colleagues who are uveitis specialists and immunologists, they use them on my patients, and I work in conjunction with them. As far as the glaucoma treatment, glaucoma tubes are the standard, but again, there are different procedures that can be used. Angle surgery, especially in children with uveitis. We have data on goniotomies, and angle surgery is becoming more and more popular. We have no data in terms of MIGS and their applications in uveitic glaucoma. I think that's an area that's going to evolve over the coming years, and as we get better tools, I'm hopeful that we'll be able to treat those patients better.